So this particular cohort was part of what's been called the STOMP trial, which has been looking at various combinations with Selinexor, which is an exportin 1 inhibitor. And this is a novel mechanism of action. And the hope here is that by inhibiting exportin 1, you will retain some proteins that will help help slow down cell proliferation, primarily P53. That's a big one here. And Selinexor has been around now for a number of years, and it was originally approved by the Food and Drug Administration in combination with dexamethasone, and the original dose was 100 milligrams, actually twice a week. And what became apparent fairly quickly was that that dose had activity, but there was a lot of side effects related to it, primarily GI side effects related to Selinexor. And what's really happened in the last few years then is using lower doses of Selinexor in combination with other agents in order to look for synergy and just exploit the mechanism of action here. So STOMP has been a platform that has looked at a number of different combinations, and one of those is Selinexor in combination with oral pomalidomide, so that you have an all oral regimen, which is obviously very patient friendly. And one of the things that's been done in these particular explorations of doses is to use lower doses of Selinexor. So what was presented by Dr. Balchevik was combinations using Selinexor at a dose of 60 milligrams per week, as well as 40 milligrams per week in combination with standard doses of dexamethasone and pomalidomide. And what we found was that even in patients who were quite refractory, the response rates were really pretty exciting. Normally in this patient cohort, we know that the average progression-free survival once you're hitting third-line therapy is about 4.5 to 5 months. It's very small. And in these particular cohorts, we were seeing response rates that were in the 7, 8, 9 month and longer, and some complete responses. So I think that we're very excited again about a number of features: novel mechanism of action, tolerability, which was there at these lower doses for patients, and really the portability, which is a nice feature. One of the things that is becoming very apparent as we use more combinations as first-line therapy, so now quadruplets have really entered the field, meaning that a patient is getting an IMiD drug, a proteasome inhibitor drug, an anti-CD38 antibody, and steroids as part of their initial treatment. One of the concerns is that patients are very quickly going to become resistant to drugs much earlier than they used to. And this also may pertain to some of the cellular therapies. Right now, we've got Cilta-cel that is approved as second-line therapy. We've got ide-cel approved as third-line therapy, and the bispecifics are there too. And so I think we are very interested in novel combinations in particular that will have activity. And one of the publications that was also at ASH, which was presented by the Myeloma Consortium, was looking at bridging therapies, moving towards CAR T. And this is an area that we really have a lot of debate about what the best agents could be. And one of the interesting things, they presented some data on bridging therapy in a poster. And one of the take-home message of the poster was, well, patients who are getting bridging therapy maybe are not responding as well, or as long, I should say, to their CAR T. But if you broke down what they were getting for their bridging therapy, those individuals, and there weren't very many of them, I think there were 21 in the poster they presented, who received Selinexor-based combinations, actually did really the best in the group in terms of their PFS. And so I think there are a lot of, there's an interest in looking at Selinexor in particular about whether it can at least support or perhaps even improve T-cell fitness, meaning that it might be a very ideal lead-in to various cellular therapies, particularly if a person has already had one previously. One of the most interesting abstracts that was presented at ASH was using selinexor as initial therapy along with some of the standard combinations. And in this case, they were sort of alternating between an IMiD cycle and then a PI cycle in combination with selinexor. Presumably, I think part of the strategy behind that was to make sure that they weren't seeing toxicity. And the newly diagnosed patients in this particular group had about a 95% response rate, which is really pretty good. I think what we would like to do is figure out very strategically how to use selinexor better. And I think certainly combinations like pomalidomide, one of the ones that we particularly like is selinexor in combination with carfilzomib and dexamethasone, which has seemed to have activity, and figure out if this is maybe the best lead-in to a cellular therapy treatment, or in particular, if somebody is really triple class refractory, meaning they are an IMiD, they are a PI, an anti-CD38 resistant, that selinexor may be the next best category to consider in those particular patients in that situation, particularly as you're trying to maybe organize a cellular therapy intervention, which can really take some time. I think the take-home message for SPD that we really liked is we saw activity, we saw manageable side effects. I think, again, for those of us who have used selinexor for a number of years, lower doses are better tolerated, and the supportive care is extremely important, meaning you really have to let patients know that it is important to make sure they're drinking fluids. Olanzapine has been very helpful for patients. I think if you really inform patients about that particular group of side effects that they can experience, that's really helpful. But the idea that people can take a quite effective regimen and not need to come into clinic all the time for monitoring has a lot of appeal.